Hello, ladies and gentlemen. Our public health education program about medical oncology and multidisciplinary oncology series, new broadcasting period and new multidisciplinary oncology, Northern Cyprus, Turkish Cypriot TV channel, Monco Tres, free TV channel. The first program, Chirurgical Oncology, Surgery Oncology, and Public Health Education program just only attributed the medical oncology side, general information, and not deep, detailed that the interested doctors and physicians. Chirurgical oncology, contemporary principles and practice. This book originated United States of America. Neoplasms of the skin. Neoplasms of the skin. Précancéreuses lésions and carcinoma in situ, squamous cell carcinoma, epidermoid carcinoma, and basal cell carcinoma. Introduction. Malignant neoplasms of the skin are the most common malignancies in all geographic regions inhabited by Caucasians. The most common skin cancers are classified as non-melanoma skin cancer, which includes basal cell carcinoma, squamous cell carcinoma, and carcinoma in situ, Bowen's disease, erythroplasia of Queyrat, and keratoacanthoma. This chapter will address the epidemiology, causative factors, diagnosis, staging, and treatment of non-melanoma skin cancer, as well as precancerous conditions. Incidence and epidemiology. Non-melanoma skin cancer is the most common malignancy in the United States. The projected incidence of non-melanoma skin cancer in the United States was estimated to be 900,000 to 1,200,000 cases of 1994 alone. The rates are even higher in Australia, where the incidence is the highest in the world. The standardized incidence of the treated non-melanoma skin cancers in Australia in 1984 was 827 per 100,000 versus the 19 per 100,000 world average. There is a profound north to south gradient in incidence of non-melanoma skin cancer due primarily to differences in exposure to ultraviolet light. Caucasian individuals living in the southern United States have a higher incidence of non-melanoma skin cancer than those living in the northern states. The incidence of non-melanoma skin cancer also appears to be rising in British Columbia. From 1973 to 1987, the incidence of basal cell carcinoma increased by 60.6% in men and 48.4% in women. And squamous cell carcinoma increased by 59.2% in men and 67.4% in women. Significant increases have also been observed in the United Kingdom. From 1978 to 1991, basal cell carcinoma was found to have increased 235%, and squamous cell carcinoma by 153%. Etiology, external factors. It is almost universally accepted that ultraviolet light is the single most important etiologic agent in the development of skin cancer. Ultraviolet light acts as tumor initiator and promoter, causing DNA mutations associated with immune suppression. It has been well established that sunburn and carcinogenesis are induced by ultraviolet radiation in the spectrum of ultraviolet light B and C, UVB and UVC, 250 to 320 nanometer. Ultraviolet light A, UVA 320 to 440, can also produce sunburn and augment the sunburn effects of the UVB, but is approximately 1,000 to 10,000 times less mutagenic than either ultraviolet B or ultraviolet C. Absorption of ultraviolet lights by DNA produces an excited state that induces the formation of pyrimidine dimers. These are usually rectified by excisional repair, DNA level, molecular level. Our DNA all the time come across or joining so many mutagenic and carcinogenic effect and our macromolecules DNA's existence different style repair system that the correct these repair mechanisms are eventually overwhelmed and become ineffective under condition of constant UV bombardment, such as repeated sunburn. Ineffective excisional repair leads to partial defect, repair mutation, and carcinogenesis, altered metabolism, or cell death. After decades of faulty DNA repair, cutaneous malignancies can develop in susceptible individuals. It has been suggested that skin cancer induction by ultraviolet B is initiated by early and initial DNA repair. Cells survive the repair but now have abnormal replication mechanisms that favor errors in DNA replication, which promote neoplastic change. Inherent defective repair mechanism may predispose individuals to non-melanoma skin cancers. Individuals with a history of basal cell carcinoma exhibited decreased DNA repair after exposure to UV radiation and more frequent basal cell replication than normal controls. The exact relationship between this observation and the development of skin cancer in a susceptible host is not entirely clear. Ultraviolet light also causes mutations in the p53 tumor suppressor gene, which is found in squamous cell carcinomas. This protein acts as a tumor suppressor by promoting apoptosis, programmed cell death of cells with DNA damage. Additional support for the role of ultraviolet light in development of non-melanoma skin cancer is the site distribution of these lesions. By far the most frequent location of non-melanoma skin cancer in Caucasian for both genders is the face, followed by the neck, trunk, upper extremities, and lower extremities. UVB, ultraviolet B, as well as UVA, also appears to promote tumor formation by selective immunosuppression. Ultraviolet irradiation appears to affect the host cell-mediated immune system by shifting to the suppressor T cell pathway over the helper T cell pathway, thereby altering immunologic surveillance and rejection of tumor cells. The helper T lymphocyte suppressor T lymphocyte ratio is abnormally low, and the absolute T suppressor count is high in individuals with a history of heavy ultraviolet exposure and multiple myeloma skin cancer. Contact hypersensitivity, also a cell-mediated process, is also inhibited by ultraviolet exposure. Although ultraviolet A is carcinogenic, especially in combination with ultraviolet B, ultraviolet A exposure may be protective to the skin because it stimulates the production of melanin, decreasing the risk of sunburn. There is a good evidence, however, that exposure to 8-methoxypsoralen and UVA, mutagenic as well as immunosuppressive, patients who have been exposed to long-term methoxypsoralen are the significantly increased risk of developing non-melanoma skin cancer, particularly if the number of exposures is above 100 and the dose is greater than or equal to 250 J centimeter square. Ultraviolet C wavelength less than 290 nanometer is effectively filtered by ozone layer in the stratospheric atmosphere and does not reach the surface of the Earth. Depletion of ozone layer by physical high altitude supersonic aircraft and chemical volatile hydrocarbons means as rise concern about the increased exposure to all wavelength of UV light. The most recent theoretical estimate for increased risk of non-melanoma and melanoma skin cancer is that 1% decrease in the stratospheric ozone may increase non-melanoma and melanoma skin cancer by 2.3%. X irradiation produces cutaneous malignancies in a manner similar to ultraviolet induced carcinogenesis. In the past, many of these cancers occurred as a result of chronic occupational exposure. Exposure of patients to direct X irradiation and physicians and technicians to scattered X irradiation has been greatly reduced since the turn of the century, and the incidence of these tumors has decreased dramatically. However, skin cancer is still seen as a late sequela of the therapeutic radiation, such as past treatment for acne or skin cancer. Numerous potential chemical carcinogens have been extensively studied. These include polycyclic and aromatic hydrocarbons, and to a lesser extent that pitch, soot, cresol, asphalt, and diesel oils, among others. The actual incidence of carcinomas attributable to these substances is unknown. Cutaneous malignancies, particularly squamous cell carcinoma, have long been associated with arsenic exposure through medicine as well as pesticides. This has been especially problematic in Asian countries where arsenic was used in proprietary medications and may be an under-recognized factor in this country. Arsenic exposure is associated with internal malignancies, especially of the lung and bladder, that classically present after the skin cancer are apparent. Host factors. Skin color is the single most important host factor in the development of non-melanoma skin cancer. Melanin gives skin its color and is our principal cutaneous sun protector. Individuals with the lowest concentration of melanin tend to be of Celtic origin. These very fair Caucasians are prone to serve sunburn after relatively short sun exposure and are at increased risk of developing cutaneous neoplasms. In contrast, native black Africans have skin that is rich in melanin burn only after extensive sun exposure and rarely develop sun-related neoplasms. Cricker found for Australians that an increased risk of basal cell carcinoma was strongly associated with fair skin color. Inability to tan, birth or early age of arrival in Australian, Northern European ancestry, presence of multiply nevi, and presence of solar elastosis, cutaneous sun damage. A sun reactive skin typing system proposed PATAG is used frequently in dermatology as a counseling tool to educate patients about the harmful effects of sun exposure and sunburn protection. Skin types are based on genetically determined melanin content of skin, skin color, facultative skin color, ability of skin to produce protective melanin, and tan. Skin types 1 and 2 generally describe persons of Northern European extraction. Types 3 and 4 describe Southern Europeans, Northern Mongolian, and Mediterraneans, and type 5 and 6 describe African darker Mediterraneans and Southern Mongolians. Immunosuppression, whether from UV exposure or otherwise, increases the risk for non-melanoma skin cancer. This has been especially well studied among renal transplant patients. The overall risk of developing non-melanoma skin cancer is 40% at 20 years after renal transplant. The risk is 43.8% at 7 years after heart transplant. Risk is further increased in the both cases in light skin type and with history of prolonged UV exposure. Increased risk of non-melanoma skin cancer has also been associated with chronic corticosteroid treatment and altered immune state such as lymphomas and leukemias. Human papillomavirus infection has also been associated with non-melanoma skin cancer, especially in immunosuppressed individuals. Human papillomavirus is frequently found in precancerous lesions and squamous cell carcinoma in renal transplant patients. You know, renal transplant patients need to immunosuppression therapeutic agent using. So this loss of balance condition, general pathogenic agents and immune system balance losing, and there's starting carcinogenesis period. This association is not dramatic in the general population. Human papillomavirus type 16 has been associated with Bowen's disease and squamous cell carcinoma of the fingers, while virus type 16 and 18 have been associated with squamous cell carcinoma of the genital tract. The association between human papillomavirus and non-melanoma skin cancer on other areas of the body is less clear in the normal host. However, epidermodysplasia verruciformis is a disorder in which widespread infection with human papillomavirus, primarily types 5 and 8, produced multiply flat warts which tend to develop into squamous cell carcinoma. Widespread non-melanoma skin cancer, several of which were positive for type 16 or 18 papillomavirus, have been reported in a patient after 10 years of PUA therapy for psoriasis. In addition to epidermodysplasia, verruciformis, other cutaneous disorders that have an increased risk of non-melanoma skin cancer include xeroderma pigmentosum, basal cell nerve syndrome, and albinism. The classic inherited disease of defective DNA repair is xeroderma pigmentosum. By the second decade of life, these patients have typically developed hundreds of cutaneous malignancies, primarily in sun-exposed areas that are attributable to faulty DNA repair. Individuals with basal cell nervous syndrome, Gorlin syndrome, an autosomal dominant disorder, genetically develop numerous basal cell carcinomas starting in the second decade of life. Other defects seen in this genodermatosis include palmar pits, dental cysts, bifid ribs, spinal cord defects, broad nasal root, hypertelorism, and myriad disorders of the central nervous system, gastrointestinal system, bones, and other organs. It has been associated with non-cutaneous tumors such as fibrosarcoma, medulloblastoma, rhabdomyosarcoma, meningioma, ovarian fibroma, and cardiac fibroma. The gene for Gorlin syndrome has been cloned and mapped to 9q22.3. A point mutation is present, and loss of the second allele leads to tumor formation. An association between UV exposure and malignancy has been established in these patients. Albinos lack skin pigment, are unable to tan, and are at increased risk of developing skin cancer. Methods of treating skin cancers. Different therapeutic modality: topical, chirurgical, excision, mock surgery, electrodesiccation and curettage, cryosurgery, dermabrasion, laser abrasion, other systemic retinoids, interferon, photodynamic therapy, and so on. But detailed, just only doctors and physicians, not public health education. Precancerous lesions and carcinoma in situ. Different actinic keratosis, different comments and expression, but I don't want to enter this detail. Clinical manifestation. Actinic keratosis may start out as ill-defined pink to red macules or papules with telangiectasias. As they progress, they develop adherent scale that is difficult to remove. Removal of the scale may produce bleeding. Point left untreated, the scale becomes hypertrophic. Bowen's disease, clinical manifestation. Clinical, the lesion appear as sharply demarcated red to brown plaques with very fine scale or crust, little or no surface elevation in present, and induration is usually absent. As the lesions transform into malignancies, they become indurated and the surface tends to be irregular. When the lesions occur on the fingers, they may mimic eczema and are often treated unsuccessfully with eczema treatments. Erythroplasia of Poirot, keratoacanthoma, different details. Squamous cell cancer, epidermoid carcinoma. Squamous cell cancer is the second most common skin neoplasm in Caucasian and accounts for 20% of skin cancers. The incidence among Australians is 201 per 100,000 in the non-white race. Squamous cell carcinoma is the most common skin cancer. Squamous cell carcinoma is generally a disease of the middle-aged and elderly. Most squamous cell carcinoma that occur is Caucasian, arise on sun-exposed areas, principally the head, neck, and extremities. In general, in African Americans, squamous cell carcinomas occur on some protected areas. However, in the study of 163 black patients treated at Charity Hospital in New Orleans, Moore and Perniciaro found that the most common sites of squamous cell tumors were the face and lower extremities. Sunlight exposure may have contributed to frequency of facial tumors at 33.9%. Collectively, the predisposing condition to cancer at the other side was a history of scarring Similar observations have been recorded in reports from India and Singapore. Etiology and pathogenesis. The development of the squamous cell carcinoma strongly associated with prolonged sunlight exposure and fair complexion. This is evident in Caucasians with excessive sun exposure, such as residents of Australians and New Zealand, as well as in sailors, fishermen, ranchers, and farmers. The incidence of cutaneous squamous cell carcinoma is markedly increased in the immunosuppressed patient. This is particularly apparent in transplant patients who are on immunosuppressive agent for extended period of time. Renal transplant patients are at 250 times increased risk of developing cutaneous squamous cell carcinoma. Literally hundreds of squamous cell carcinoma may be found on all areas of the body with a predilection for sun-exposed areas, although the incidence of basal cell carcinoma is also increased in this population. The normal ratio of basal cell carcinoma, squamous cell carcinoma is reversed and squamous cell carcinoma predominate. These tumors are also more aggressive. Cutaneous squamous cell carcinoma has also been associated with the human papillomavirus epidermodysplasia verruciformis. Is a rare familial disorder in which the face, neck, hand, and knees are covered with multiple dome-shaped warts. Papillomavirus type 5 and 8 have been isolated from these lesions. Non-melanoma skin cancers develop in sun-exposed area in 25% of these individuals. The Buschke-Loewenstein tumor or varicose carcinoma in a rare tumor of the genital and perineal regions. It occurs most frequently on the glans or prepuce of uncircumcised males. This tumor has been associated with human papillomavirus type 6 and 11 in both its benign and premalignant stages. Although it occurs rarely, squamous cell carcinoma is the most common cutaneous malignant lesion among African Americans. It is 20 more common than basal cell carcinoma. Black albinos are at markedly increased risk of developing squamous cell carcinoma. Blacks with vitiligo, however, are not an increased risk of developing squamous cell carcinoma. External factors such as exposure to chemical carcinogens, delayed effect of X irradiation exposure, and possibly burns, scars, and chronic ulcers, Marjolin's ulcers, play a significant role in the carcinogenesis of squamous cell carcinoma in black individuals. These factors play only a minor role in carcinogenesis in Caucasians. Unusual skin cancer associated with chronic skin irritations and direct trauma are seen in the Kashmir region of northern India. In this frigid region, earthenware pots full of hot coals, and leaves are held against the abdomen for warmth. The skin exposed to the pods developing chronic dermatitis, burns, and eventually scars. Squamous cell carcinoma or the cancer tend to developing in areas of scarring. Additional evidence linking squamous cell carcinoma with scarring was presented by Autel, who described squamous cell carcinoma developing in chronic leg ulcer and following trauma, especially burns, in the South African black population. I would like to say again our new theory, only real theory about carcinogenesis. Efruzhu cancer carcinogenesis, North Cyprus theory and laws. 1. Mutations group identity by macrophages. 2. Inadequate energy. 3. Chronic inflammation. 4. Normal DNA suppression. All 100% completely. Cancers obligatory, absolutely dependence. Efruzhu cancer carcinogenesis, North Cyprus theory and laws. Carcinogens and mutagens just only trigger function, but cancer cell identity, dual identity, binary identity, mutations group identity, and original DNA identity. But original DNA identity and its dynamics suppressed, silenced, and dominant mutations group identity that comes from outside by more than one macrophage's DNA segments probes. Just only. Yes, another important other subject, this chapter, basal cell carcinoma. Basal cell carcinoma. Basal cell carcinoma is the most common neoplasmo-Caucasian, and the incidence is increasing. It is uncommon among African Americans. The head and neck areas are by far the most frequent sites of basal cell carcinoma in both men and women, with 80% of lesions occurring here. Basal cell carcinomas have been reported to occur in non-sun exposed area. Basal cell carcinoma do occur in non-white races, but are less common than squamous cell carcinoma. In a comprehensive study of skin cancer in African American conducted in 1988 at Howard University, 89% of basal cell carcinoma were found to be on sun-exposed areas. Most lesions occur at or after age. Etiology and pathogenesis. It is widely accepted that ultraviolet light plays a crucial role in the pathogenesis of basal cell carcinoma. However, some lesions can't be completely explained by prolonged sun exposure. Basal cell carcinomas are known to occur at sites protected from sun exposure, such as behind the ear and the inner canthus. Basal cell carcinomas have been reported on the vulva. In some studies, an association between cumulative sun exposure and risk of basal cell carcinoma was not found. Genetic factors also affect risk of developing basal cell carcinoma. A markedly increased risk of developing basal cell carcinoma is associated with Gorlin syndrome. First, basal cell carcinoma may occur in the second decade of life. Individuals with xeroderma pigmentosum have defective DNA excisional repair and are therefore at increased risk of sunlight-induced non-melanoma skin cancers starting at the mean age of 8 years because of their tendency toward light skin, blue eyes, freckling, and inability to then people of Irish, English and Welsh descent are also at increased risk of developing basal cell carcinoma. Exposure to chemical carcinogens and ionizing radiation has also been associated with an increased risk of basal cell carcinoma, although to a lesser degree than squamous cell carcinoma. There is substantial evidence linking basal cell carcinoma with ingestion of trivalent arsenic and exposure to therapeutic X irradiation. Basal cell carcinoma have been reported to occur in scars induced by burns, vaccination, chickenpox, and chronic leg ulcers. Clinical manifestations. Patients frequently complain of bleeding or crusting lesions that may heal partially but tend to recur. Most basal cell carcinoma occur on sun-exposed regions such as the head and neck area. Basal cell carcinoma are categorized in subtypes that have characteristic clinical presentation. These categories include nodular, morphiform, superficial, and pigmented. Nodular basal cell carcinoma present as translucent, pearly papules of various sizes that are traversed by tortuous telangiectatic blood vessels. As the lesion ages, the center becomes flat and potential crusted, and the peripheral borders become raised and pearly. The thickened borders are produced by vertical rather than horizontal spread of the tumor. The center may eventually ulcerate, producing a rodent ulcer. Nodulocystic tumors may have the appearance of pustules or epidermal cysts. Morphear forum. Basal cell carcinoma present as ill-defined, white, waxy, and sclerotic plaques. They are usually devoid and telangiectasias and may be only slightly rise above the surrounding normal skin. The lesions tend to be firm, depressed, and smooth. They are less likely to have pearly features than nodular basal cell carcinoma. They often resemble scars or scleroderma. Horizontal spread rather than vertical occurs in the superficial basal cell carcinoma. Scaling plaques without telangiectasias. These tumors are potentially confused with Bowen's disease or localized eczema. Pigmented basal cell carcinomas are identical to nodular basal cell carcinoma except for pigmentation. They may be sprinkled with pigment or may be entirely pigmented. These occur more frequently in people with dark skin types. They are easily confused with malignant melanoma. Yes, so many detailed and therapeutic modality, and this program finished, and this chapter existence so many histological, histopathological, and clinical pathologic figures. But these belong to doctors and physicians, general practitioner, and specialists. And another malignant melanoma. Malignant melanoma. Incidence. The incidence of malignant melanoma has increased dramatically. In the United States, the lifetime risk in 1930 was 1 per 1,500. In 1981, it was 1 per 250. In 1985, 1 per 150. And in 1996, it rose to 1 per 87, 1 per 74 white males. There are about 47,700 new invasive cases diagnosed annually and 40,000 in situ cases. The lifetime risk is 1/74 for the year 2000. This increase in melanoma incidence is the worldwide phenomenon, and it is real and not artifactual. The death rate from melanoma has continued to rise about 2% annually, although the annual increase in melanoma is 6%. The survival rates for people with localized melanoma have improved from 50% in the 1950s to about 90% today. Therefore, although there is an increase in the absolute death rates due to a larger number of cases, this has not kept pace with the incidence in recent years, primarily as a result of earlier diagnosis and consequently higher survival. Etiology. The major etiologic factor involved in the Caucasian or malignant melanoma is ultraviolet radiation exposure owing to its capacity to cause erythema. It is presumed that the 290 to 320 nanometer ultraviolet B range of ultraviolet radiation may be the range that tends to cause melanoma, although studies on the users of sun tanning baths, ultraviolet A, 320 to 400 millimeters, suggest that the ultraviolet A range also may contribute. The evidence that solar radiation is implicated derives from the epidemiologic studies showing an increase in the incidence of melanoma as the latitude decreases in the coastal areas and for people spending their vacation in sunny climates. Both latitude and altitude affect the intensity of exposure to sunlight. There is a considerable time lag between repeated sunlight exposure which induce and then promote melanoma and the subsequent clinical appearance of this neoplasm. Apparently burst of UVB exposure, ultraviolet B exposure, early in one's life present a higher risk than simply chronic long-term exposure. The gradual depletion of the ozone layer may be another factor, since this layer is estimated to have decreased by 3% to 7% since 1969. Apparently, each 1% decrease in stratospheric ozone results in a 1% increase in the incidence of melanoma, partly because of its degree of efficiency as a filter for solar radiation. The degree of skin pigmentation of the individual or race is another factor affecting the incidence of melanoma. Whites have a higher incidence of melanoma than non-whites. Thus, whites have 10 times the incidence of melanoma as blacks. In blacks, melanomas arise more commonly in less pigmented skin areas, for example, the palm, soles, and mucous membranes. About 8% or to 12% of melanomas occurred within familial, which indicated the role of hereditary for these patients. Initially, it was Clark who described the association between the clinical entity of multiply nevi with unique clinical and histopathologic characteristic described as the BK-MOL syndrome. BK were initial of the first two patients with this syndrome and the higher risk of developing malignant melanoma. The term familial atypical multiply mole melanoma FAPREM was later proposed, and more recently the condition has been called the dysplastic nevus syndrome. Patients with DN may be DN dysplastic nevus may be associated with familial cutaneous melanoma, but the majority of these patients don't have such a history. They often have numerous and sometimes hundreds of typical moles. Histologically, DN manifests disorder, proliferation of atypical melanocytes in the lentiginous epidermal pattern. About 1.8% to 7% of all whites and 30% of 50 to 50% of patients with melanoma have DN dysplastic nevus. Person with sporadic dysplastic nevus have 6% lifetime risk of developing melanoma. This risk approaches 100% for those with DN changes from the normal melanocyte to metastatic melanoma, provide the opportunity, early detection, therapeutic intervention. Preventive measures to prevent malignant melanoma involve public education programs emphasizing the risk for developing skin cancer by excessive exposure to sunlight, particularly for those with fair skin. Reducing exposure to sunlight through avoidance of such exposure, the wearing of protective clothing, and the use of sunscreens is an important goal. Sunscreen products that offer a broad spectrum of protection, that is also filtering to some extent UVA, ultraviolet A, and rating of at least 15 are recommended. Rating of at least 15 are recommended. However, this is the long-term approach, since the present that benefit to reducing the degree of exposure to sunlight will not manifest itself for a few decades, given the long time required between induction and promotion to clinical appearance of melanoma. Increasing early detection of this neoplasm by increasing public and professional awareness of this condition represent the short-term approach in reducing mortality. Clinical manifestations. There are usually no subjective symptoms associated with the appearance of localized malignant melanoma, with the exception of occasional itching itching in the area of the mole. The characteristic suggestive of melanoma for specific skin lesion can be memorized through the use of mnemonic A, B, C, D, E, symmetry, B, border irregularity, C, color variegation, D, diameter larger than 6 mm, and E, evolution that showing relatively rapid change in the course of weeks or a few months. When the history is reliable, the last characteristic is important because benign moles remain stable and change only slightly over the course of years, whereas melanomas change perceptibly in course of a few weeks or months. Mole change that the suspicious of melanoma include a change in color or shape, an increase in diameter, a surface that becomes more raised and irregular, and lesions that bleeds, ulceration of the surface epithelium of mole is also a suspicious sign. Itching is symptoms 20% to 46% of the lesions. The four major growth patterns of melanomas are superficial spreading melanoma, nodular melanoma, lentigo malign melanoma, and acral lentiginous melanoma. SSM is the most common lesion. Superficial spreading melanoma is the most common lesion, about 70% of occurring as a pigmented flat lesion that often arises in a pre-existing mole that initially tend to spread readily and only later may develop nodules within its perimeter. Nodular melanoma, the second most common variety of the melanoma, 15% to 30% of lesions, is biologically aggressive, often arising de novo and presenting a raised domed surface that may resemble a blood blister and hemangioma with different hues. Different hues of color. Lentigo malignant melanoma, 4% to 10% cases, is the distinct variety of flat tan brown lesions, typically located in the face of elderly individuals and slowly evolving over several years from the precursor form lentigo malignant. And acral lentiginous melanoma, 2% to 8% of cases, is usually located in the plantar or palmar surfaces in the skin of older people. This type tends to have a worse prognosis than SSM or LMM. Although still useful to clinicians, the categorization of melanomas according to the growth pattern has been superseded, largely with regard to prognostic implications, by the microstaging method concerning the primary lesion. Subungual melanoma is rare from the cutaneous melanoma, presenting as a brown-black discoloration of the nail bed that may be confused with hematoma, lacking clear history of trauma or failure for this discoloration to clear within 2 to 4 weeks should lead to biopsy, usually by removing portion of the nail plate, pigmentation of the adjacent cuticle or skin supports the clinical diagnosis of subungual melanoma. Subungual melanoma. About 50% NM, nodular melanoma, and 10% of subungual melanomas may lack pigment amelanotic. Lack pigment amelanotic, in which cases the suspicion of the neoplastic lesion is raised by the general appearance of growth. Approximately 4% of melanomas appear in the subcutaneous tissue, nodal basin or other sites without any known primary skin site. In these patients, either the primary skin site existed at some point and regressed spontaneously unbeknown to the patient, of these melanoma sites in other than skin areas represent primary growth sites from ectopic melanocytes to these areas which underwent malignant degeneration. Yes, diagnosis, pathology, microstaging, staging the disease, treatment, localized melanoma, and different details. And some chirurgical surgery operation figure show us for doctors and physicians, specialist general practitioners, and different therapeutic modality. That's all. This program just finished now. And thank you so much. Thank you very much. You are patient. I believe very long program, and you should divide it short segments and step by step listening this program, watching this program, and I hope useful all over the world citizens. Prophylactic, preventive medicine, public health education program. And next program, I hope, cancers of the head and neck. Thank you so much. Thank you very much. From North Cyprus, Turkish Cypriots. See you later.